Hi, I would like to start this pharmacokinetics tutorial. I believe that this series of tutorials will help you to understand the topics clearly and a firm pharmacokinetic base. This is the second part of the tutorial. You can cite the basics of pharmacokinetics in the first part for a better understanding. So let's start. There are a lot to know in the world of pharmacokinetics. So today we'll discuss about bioavailability. So this bioavailability is the proportion of an administered dose that is absorbed chemically unseen into the systemic blood circulations. So you have to understand the word chemically unseen into the systemic blood circulation. That is where the bioavailability of a drug means. So this is would be especially important with an oral dose of a drug, where part of the dose may be chemically degraded during the absorption process and thus absorb a mix of authentic active drug and background products. Only the unseen material is considered as bioavailable. So it is also sometimes called fractional availability, and it is denoted as the word F in pharmacokinetic calculations. Bioavailability is reported as a proportion. So if half of the administered dose eventually gets into the circulation, the viability could be quoted as 0.5 or 50%. So we can see here the different viability of drugs by various routes. You can see here the most one is the intravenous because we give the drug directly into the blood. And however, the viability of like oral and rectal route of administration, it ranges from 5 to 100. So it's not like that all drugs with oral formulations will have a low viability. Some drugs retain the viability close to 100%. So what happens when you take a drug by oral route? So it has to pass through many barriers. The first is to break down into distribute into tiny material particles to get absorbed. So this is being done in the stomach generally. Next, whether the drug is formable or not, we have discussed this in the previous video. The drug passes through the portal vein, then undergo first pass metabolism in the liver, and after that, if the first pass metabolism occurs, then it moves to the hepatic vein, then into the systemic circulations. We'll talk about the viability in also in our subsequent slides. So speaking particularly about the gut lumen, okay. So there are many barriers like gut lumen is a complex and dynamic environment presenting several barriers to oral drug delivery. This picture speaks on the factors that influence the absorption at various parts of the GI tract. The variable pH range, the plethora of intestinal and bacterial enzymes, and presence of numerous transporters have a significant impact on the solubility, stability, and absorption of the drug compounds. You can pause this slide and can have a look at it, the various components. So during absorptions, so for example, after oral administration, a drug may be incomplete absorbed. For example, I'm just like to give the example of digoxin. There's only 70% of dose of digoxin reaches the systemic circulation. So what about the rest of the drug? So this is mainly due to lack of absorption from the gut. So means it is being not absorbed. Means it is being means it will be excreted to the fecal matter in most of the cases. So the drugs that are either too hydrophilic, the drug cannot cross the lipid cell membrane. If the lipophilic, the drug is not soluble enough to cross the water layer adjacent to the cell. So there are various factors that this hydrophilic that is more water soluble, or if the drug is more lipid soluble, if the drug is more ionized. So these are the factors that helps these are limiting factors you can say for a drug to be absorbed from the stomach. So, the first potential cause of incomplete viability is that the dosage form may fail to disintegrate or allow the active ingredient to dissolve fully. With good formulation, this should not arise, but it needs to be borne in mind as a possible problem. So, this if a drug fails to disintegrate in that case, it will not get the required viability of a drug, and hence the effect of the drug will not be pronounced. Secondly, there may be breakdown of the active ingredients within the gastrointestinal content. That is also one of the possibilities. Three possibilities are particularly obvious. The first one is the chemical. You can see the stomach has a high pH of 1, so molecules simply cannot withstand this extreme acidity. So without a special enteric coated formulation, such a drug will not be fully uh, orally bioavailable. Next is about the enzymatic. The GI tract contains many digestive enzymes. For example, insulin, if you take it orally, it will be break down by proteases enzyme. That's why it will not in the market. You will not find oral insulin in the market. The third one is the bacterial. So you can the upper part of the gut, that is the stomach and the small intestine, are normally partially sterile. So attack by bacteria is not a problem in this part, so long as the drug is absorbed rapidly enough to have left the gut by the time the GIT contents, means that the drug reaches the colon. Uh, However, relatively polar drugs such as digoxin is absorbed very inefficiently, and it's likely that a significant part of those is still present when the GIT contents reaches the colon. Thus, the extensive colonic flora had an opportunity to degrade some part of the this dose of digoxin, and ultimately it affects the bioavailability. And here you can see that again some drugs have they have some chemical reactions inside the GI tract. For example, if you take tetracycline with milk, so it is tetracycline bind to the polyvalent cations of calcium, leading to a non-absorption of the antibiotic. So these are the some factors which may affect the absorption. So this is a chart in which the shown the preventing the oral bioavailability, and you can see here some drugs have low oral bioavailability. Gentamicin is one of them. You cannot say you will not find the market any oral dose of gentamicin because gentamicin has a very high water solubility and inadequate fat solubility to undergo passive diffusion, means from the GI tract. That's why it is the oral bioavailability is less than 5, and it has been given generally for intramuscular or IV doses. Other drugs like verapamil, lidocaine, and propanolol, okay, are all subject to extensive first dose metabolism. You take the drug orally, and ultimately it will metabolize in the liver. That's why the bioavailability is less in this case. The bioavailability of digoxin is compromised by greater low lipid solubility. This is not as extreme as that of gentamicin, but absorption is still slow and inefficient. Digoxin does. But again, the valproic acid is one of the examples of which has a high oral bioavailability. That is close to 100, not exactly 100, but close to 100. So what happens if you take the drug not by oral but through sublingual, buccal, or rectal administration? So the benefit of it is that if a drug is absorbed from either end of the tract, blood carrying the drug will leave the GIT and join directly with the general circulation without passing for the liver. So this is the liver, and you will bypass this liver, and ultimately the first metabolism that is being seen in the liver is it can be avoided. So adjustment for the mouth may be achieved if drugs are administered as sublingual, that is held under the tongue, or buccal, that are held in the teeth and the sick formulations. One commonly used drug in the sublingual is the nitrate. When you have enteropectoris, then this is how nitrate is being given. So next about the bioavailability in a drug development. So if we have a drug, suppose D, and we have a route, different route for which the bioavailability is equal to F, then the actual amount delivered will be delivered drug into B into F. So you can see, for example, we have a with bioavailability values like 90 to 100% here. We are faced with only 10% variability, which is unlikely to cause any practical problem between two drugs. Or if get in the variability seen in two patients, the variability of 10% is not very much problematic. But if the variability is like 30 to 60%, one patient A will get a concentration of like 30 milligram in the sense. So for example, and if you're at drug patient B, we have around a 60 milligram. So in that case, this is twofold increase in the concentration of drug. If the drug is toxic, then twofold increases pretty much disastrous, and in case of a for the patient in that case. So drug company don't want means if they're working in generics, or you can say if you it's a new drug also in that case, they don't want the variability is highest like twofold or in one patient as compared to another. So that is very much important in case of a drug. If a sponsor, if a company, drug company is developing an oral drug. So it's not so important as a salt factor, but you have to know about this in the PK analysis. That is the proportion of parent drug contained in the salt expressed on a weight by weight basis, expressed as, and those calculations may need to be adjusted, and sometimes if it's on the salt factor. This arises when a drug is administered as salt, but our purpose is to deliver a dose defined in terms of mass of a parent drug. So kindly read about it. I'm not going in depth about the use of the salt factor in this presentation. Just for a second example, aminophylline somehow poorly defined salt, but generally contains about 80% theophylline. Okay, So the solve factor is 0.8. Okay, which 20% is being lost. You can figure it out. So if you want to administer a dose of theophylline, but we use the drug in the form of aminophylline, we'll have to use a dose of like D divided by salt, S divided, that is 400 milligram of salt factor 0.8. So we have total dose needed in the case of aminophylline is 500 milligram because 20% has been lost. This is what is salt factor. Uh, you can have a look at it, but it's not so commonly used. So let's have a recap of the area under curve. So this is the AUC is considered the most reliable measure of a drug viability and is directly proportional in the total amount of unsensed drug. This is the systemic circulation. So this is the time component, this is the plasma concentration component, and this is the green part is the area under the curve. This is the amount of drug that is present inside the body following the administration of a drug. So how it is used, let's see in the subsequent slides. So regarding absolute viability, like there are two types of viability, absolute and relative. Let's first go with absolute. So it compares the viability of the active drug in the systemic circulation following extravascular administration. Extravascular means either you take orally, means not parenterally, that is extravascular, with the viability of the same drug following an intravenous administration. So IV versus extravascular administration. This is how what is absolute viability is. So intravenous drug administered is considered as 100% bioavailable, that is absorbed. The route of extravascular administration can be different types, and it is designated as F or ABS. So ABS stands for absorption. So absolute viability is the dose-corrected AUC of the extravascularly administered drug product. This is the test product. This is suppose it is orally I have given it the drug, and the AUC of the IV drug of the same drug. For example, if I take omeprazole example, omeprazole oral and omeprazole IV. So that is the same dose should be also give like 20 milligram oral and 20 milligram IV. This is, and then we calculate what is the AUC of these two components, and we get the absolute bioavailability. So suppose for in some instances the oral dose and the IV dose are not similar. For example, metronidazole we have 400 milligram, 500 milligram this is oral dose, and we can say 400 milligram IV dose. Means any other drugs, which is the doses are not similar in case of IV and oral. So in that case, we have a different formula. This is how it is being calculated, and you can see AUC PO is the AUC following oral administration, and AUC-IV is the AUC following intravenous administration, and this is the DIV is the dose administered intravenously, and DPO is the dose administered orally. So we have the formula, and we can calculate the corresponding absolute viability. So relative viability, what is that? If the systemic exposure of a drug in a designated formulation is compared with the same drug administered in a reference formulation. So this expresses AUC is equal to test formulation, AUC is equal to reference formulation. In that case, we have a different drugs in that case. So this is how relative viability is. Let's a different example. So this is the formula. You can see AUC is the AUC for the industrial treatment formulation A. DA is a dose of formulation A. Okay, these two are like common, and we have AUC of formulation B and dose of the formulation B. So exactly means if you don't have an IV dose in that case, for example, we don't have an IV component to it. So we try to estimate the viability of a oral component versus the sublingual component. Okay. In that case, which one has a more viability, oral or sublingual? We try to estimate that. So this is where the relative viability comes into picture. So I mentioned about the oral tablet and the sublingual. So here's an example of an oral tablet versus oral solution. Okay, so here the dose is the same, AUC is a little bit different. You can see the oral viability is 1.4%. Means only 4% difference between the two components. So it is from there is a range that is 80 to 125. So I think it fits into that range 80 to 125, and you can say that this drug is oral, whether you take oral tablet or oral solution, we don't have any much difference in the output and the concentration of drug. Uh, Generally, the three important factors, we can say main two factors that affect the viability. One is the pharmaceutical component and one is the physiological components. Let's try to understand that. So there are many pharmaceutical factors. The most important one are like particle size, salt form, crystal form, water of hydrations. They affect the viability of a drug. The other one is the degree of ionization. We'll discuss in depth regarding how degree of ionization affect the viability because this is an important thing. The next is the excipients, excipient use. For example, so these excipients and excipients are like inner substance. For example, starch, lactose, polysorbate 80, to be named a few of them, which are added to the formulation as a filling material or as a binding agents to obtain a proper granular size. So if a parent drug has a different excipients and if you make a drug with another excipients, then these excipients affect the rate of dissolutions or you can say the absorption of a drug into the systemic circulation. So for that, we have to quite sure that the excipients doesn't have a major role in the absorption of a drug if you want to change the excipients from one formulation to the another one. So next about the biological factors that affect the drug absorption. We can control the pharmaceutical factors because this is everything is being like you can decide what exactly your pharmaceutical components are. But for the biological factors, this is not in the hands of the sponsor. It depends on person to person. We can think of decreasing the variability of the plasma concentrations by looking at the various factors that may affect biological factors that may affect the absorption of these drugs. The first one for that we have to know about passive diffusion, how a drug is being absorbed from the GI tract. So most likely drugs can only cross membranes by passive diffusion. And their ability to do this depends upon their lipid solubility. Excessive water soluble drugs are likely to be unable to cross membranes. For example, gentamicin. So next is about what is facilitated diffusion and active transport. Where drugs undergo facilitated diffusion or active transport, there is a transporter protein in that binds the drug molecule and carries it across the membrane. In this case, the drug doesn't have to dissolve in the lipid membranes, and there is no requirement for lipid solubility. It is not common for all the molecules, but it is important for some of the molecules. For example, like active transport. Is an energy requiring active process which pumps drug in a defined direction. In this case, net transport is possible under any circumstances, even occurring against a concentration gradient. So it is being moved from one side of the cell to the other side with a form of energy. So that is important. The transporter molecules that carry out the facilitated diffusion and active transport are very selective. They will only bind to a transport tightly defined groups of molecules. And basically, active transport we need energy, and facilitated transport doesn't need energy, and both of them needs a carrier molecule. So this is the difference between the three of them: passive, facilitated, and active transport. You can see energy required, no, no, yes, only yes is present in active transport. Concentration gradient should be there in both the cases, why it is not being very important in case of active transport. Carrier transport, it is being used for both facilitated and active transport. So next important thing about a protein called pre-glycoprotein. So the lining cells of the gut contain pre-glycoproteins. These are located within the part of the membrane of the epithelial cells that is in direct contact with the GI content, the apical surface. For example, this is the apical surface of the cell in the GI tract. So a drug molecule is assumed to be adequately lipid soluble to undergo passive diffusion and enter the epithelial cell. However, the P-glycoprotein then binds to the drug and expels it back to the gut content, thus inhibiting its absorption. P-glycoprotein may inhibit the absorption of lipid-soluble drug that would otherwise be freely absorbed from the gastrointestinal tract. So the point is that the correct is that if a drug is lipid-soluble, then also it may not be absorbed because of this P-glycoprotein-mediated drug efflux. Next is binding to macromolecules. Drugs cannot undergo passive diffusion while bound to a macromolecule such as protein or DNA. Take the example of blood albumin, which binds a wide range of drugs. The protein molecule is far too water soluble to undergo passive diffusions. Consequently, drugs that bound to macromolecules are effectively trapped on one side of the biological membrane, unable to distribute to the other side. So, obviously, if you bind to a very big molecule, you cannot pass through the cell membrane. That is quite obvious in that case. So, some drugs there which bind in this similar fashion, and the viability is pretty less in this case in these drugs. But point is to be remembered that so if you try to see the contribution of the plasma of the drug, means suppose if this is the drug and this is bind to the drug protein, this part of the component cannot move through the cell membrane, but the other product, the free drug, can move from the blood to the tissue. So it may, you can say, it may resist the tissue in this case, but if it's measured, the total drug concentration will be higher in the blood because of the additional protein bound material. That is the important, very important, because if it's some drugs, it's not like that it will bind to all the components of the drug will bind to the this macromolecules, so you can say protein or DNA. Some part of it will be free and it can move from the other side of the cell membrane, that is in the various tissues, and it will make cause the desired effect. So both the situations that we have discussed is maybe present simultaneously. The outcome will depend upon a relatively binding affinity of the blood and the intracellular components. For some drugs, plasma predominance in the drug will be found primarily in the blood, and for others, it is like vice versa. So it will move in the tissues, and it may lead to toxicity if it continuously be there in the tissues for a long duration of time. Ion trapping arises when an ionizable drug encounters a pH pressure. For example, a basic drug contains an ionizable nitrogen atom. The stomach contains a strongly acidic, that is a low pH, while blood and tissues are approximately neutral, and larger intestine it is the higher pH. Okay. In its non-ionized form, the drug is liposoluble. I mean to say about a basic drug, and able to cross membrane by passive division. But when this basic drug meets at a higher pH, it becomes ionized and it is much polar and unable to cross. The opposite effect would be seen with an acidic drug. At equivalent, there will be higher concentration of drug in the blood than in the stomach, because in the stomach it is acidic, and we have an acidic drug. It is not ionized and it will be easily absorbed from the GI tract. The general rule is a kind of attraction of opposite. Acidic drug accumulate in basic environments and basic drugs in the acidic ones. So, one of the common example of ion trapping is about the aspirin-induced ulcers. There are a lot of mechanisms through which aspirin causes ulcers, so it is one of them. So, aspirin is an acidic drug, weak acidic drug, and we have a GI content in the stomach is quite acidic. The piece, so aspirin is not ionized and penetrates the cell membrane. Direct topical injury results from the ability of the aspirin to penetrate the mucosa that lines the gastric mucosa and to cross the plasma membrane of the gastric epithelial cells, where often the molecule dissociates. So within the epithelial cells, this molecule dissociates the aspirin and trapping hydrogen ion within the cells. So, so, so the aspirin within the gastric epithelial cells, trapping hydrogen ions within the cells and leads to toxicity. This is one of the mechanisms of aspirin-induced ulcer. So the aspirin will stay in within the epithelial cells and causes ulcer. So let's go with another example of aspirin toxicity and how the ion trapping helps. Means knowledge of ion trapping helps to reduce this aspirin toxicity. So every aspirin is reabsorbed back to the blood, although you have excess drug in the body. This is because both the drug and the urine is acidic, and this facilitates the absorption process as discussed here. Because you can see here, the urine is acidic, we have aspirin is acidic, so this is more non-ionized portion of aspirin. So more non-ionized portion, it will be absorbed into the blood. But if you give sodium bicarbonate, urine is made alkali, and so the aspirin now, you can see the pH is the alkali. So the acidic aspirin in pH 8, that is the alkali urine, it will be like more ionized portion will be there. Okay, so being an ionized, it will not being absorbed through the cell membrane into the blood. So in this case, most of the acidic drug will be eliminated into the urine. Uh, just want to conclude my presentation with an example. It's already more than 25 minutes. I don't want to extend it long. This is about the study of misoprostol of two formulations. They're trying to compare the viability. Uh, Unlikely, the viability of this misoprostol sublingual route of administration is quite high. 143. You can see the AUC 172%. It's like 72%. It is higher as compared to the oral formulation. So if it is higher, it may lead to more side effects, and it doesn't fall within the 85% and like 125%. This is the standard thing that is being accepted by the regulatory in the sense that FDA. So it is more than that, and I don't think any regulator will accept it, this form of administration, or can say any clinician will also prescribe it in the form of sublingual, unless and until something has to be done, like if you want to change the pharmaceutical components of the misoprostol so that the absorption may be decreased. The absorption is it will increase because as we know that it bypasses the phosphorus metabolism. It has been given sublingual, it is not oral. So in that case, you may have to decrease the doses also of misoprostol to what has been given here in this trial. So definitely it will not pass, and it will not be used in the case of patients. Definitely, we can discuss in depth about more BAB clinical trials in our subsequent sessions, and these are my references here. Hope you like this presentation. Please subscribe and comment if you need any further elaboration of any topic that has been presented in this slide. Thank you all. Bye bye.